Hello, I'm Dr. Craig Earl. I'm the Vice President of Cancer Control at the Canadian Partnership Against Cancer. And welcome to Modeling Our Way Out of the Pandemic, where we're going to be showcasing the importance of data-driven modeling in understanding the impact of COVID-19 on cancer care and in providing insights to help with pandemic recovery across the cancer prevention to treatment continuum. Today we have three outstanding speakers. Dr. Karen Canfell will describe the work of the COVID-19 and Cancer Global Modeling Consortium. Natalie Fitzgerald will share recent work on screening using the OncoSim model. And Dr. Talia Malagan will demonstrate the impact of the pandemic on Canada's cancer diagnoses and treatment and explore the surge that's necessary to mitigate the pandemic's effects. First, we'll hear from Dr. Karen Canfell. She's the director of the Daffodil Centre at the University of Sydney. Dr. Canfell.
Thank you very much, Dr. Earl. It's an absolute pleasure to be here. And I'm here to introduce you to the work of the Global COVID and Cancer Modelling Consortium. So the COVID-19 and Cancer Global Modelling Consortium is an effort by researchers, in fact, around the globe to come together to help configure modelling platforms to estimate the potential impact of COVID-19 on cancer and thereby to provide informed advice to governments, with a focus ultimately on helping inform governments in low and middle income countries as they rise to this overwhelming health systems challenge. And the CCGMC actually comprises over 250 members. We came together just at the onset of the pandemic, and we represent stakeholders from 38 countries worldwide. Now, thinking about the potential impacts of COVID-19 on cancer, there's actually, in fact, of course, many potential ways in which the pandemic could adversely impact short, intermediate, and long-term outcomes. First, there's the potential impact on cancer survival. There's the potential for a direct impact of the infection itself on survival in cancer patients. And of course, as is well documented, the indirect impact of treatment disruptions during lockdowns on survival outcomes. Secondly, there's the potential impact on diagnosis, either through disruptions to established screening programs or in delays in symptomatic presentation. And then finally, there's also the long-term potential to influence cancer risk via a direct impact on cancer risk from the infection itself, or more proximately perhaps, changes in relevant behaviours during the crisis and/or disruptions to primary prevention programs. So in order to model these effects and to provide informed predictions and thus advice to policymakers, there are many and varied data needs for modelling. These include information on the impact of the infection on cancer outcomes, information on the nature and timing of health system disruptions. And I want to make the point that this information needs to be dynamic and ongoing at a country or jurisdictional level. And we actually need to be able to characterise the impact of successive waves of lockdowns over time. Information on the extent and natures of changes of exposure or prevention behaviours, for example, how smoking behaviours may change, or another example, how HPV vaccination programs may be disrupted. Comprehensive information on screening behaviour during lockdowns, comprehensive and timely population-based cancer registry data, ideally stratified by treatment delivery. And then we need all of this information ideally at both the country and also at subnational levels in order to reflect risk and outcomes in specific groups and to capture inequities and impacts. Now, just to give you a quick overview of our activities as the CCGMC in different areas. Firstly, an example of what we've been doing in the area of cancer risk and prevention. Well, before turning to modelling the effects, we've actually looked at actually characterising those effects. And we have, in fact, embarked on a global systematic review of the impact of the pandemic on smoking behaviour. And I just wanted to highlight some of the results here. We've performed a meta-analysis of 33 studies over 200,000 participants across 24 countries for the first phase of the pandemic. And in that first phase, the first 6 months or so, we did find from this review an indication that the pool smoking prevalence actually may have decreased slightly, but with very mixed behaviours. In people that smoke, we found a higher proportion smoking initially more than smoking less, and also a small proportion of non-smokers who started smoking during the pandemic. So this really indicated a dynamic, heterogeneous nature of smoking behaviour. The changes in behaviour during the early phases of the pandemic were highly mixed. And of course, what's important to note here is that the long-term impact on cancer outcomes is yet to be quantified, and that is one of our ongoing aims through the modelling. Secondly, I want to give you an example of the work that we've been doing on the impact on cancer screening. We've been looking across different types of screening programs: colorectal cancer screening, cervical screening, and breast cancer screening. And here's an example where 4 different modelling teams with established modelling platforms have come together from different countries to model the impact of the pandemic in Canada, the Netherlands, and Australia. And you can see that the patterns of disruption that are projected are similar across models and countries. Essentially, that all groups predicted an initial drop in diagnosis of colorectal cancer, followed by, unfortunately, an increase over time. And we concluded that it's crucial that if disrupted screening programs ensure participation rates return to previously observed rates and provide catch-up screening wherever possible, since we found that this could mainly mitigate the impact on colorectal cancer deaths if done effectively. Finally, I want to turn to some of our work on the impact of COVID on cancer survival. This is another meta-analysis that we've been doing, 96 studies with 54 with included data on over 500,000 people with COVID. We did see a high risk of bias, and again, this is some of the early literature through the pandemic. And we also found that there were issues with adjustment and confounding in the studies. But when we looked at studies that accounted for at least age, we found that there was a residual increased risk indicated of about 40% in people who have COVID, of dying of cancer and of experiencing a lower survival from cancer. So that's an important impact that we are incorporating into the modelling. Now, I just want to show you very quickly an illustration of how we've been trying to bring these effects together. So I've talked about 3 different aspects of cancer control: risk and prevention, cancer screening and diagnosis, and cancer treatment and disruptions. And the first cancer in which we've been able to bring together these effects and model all 3 at one time is the example of cervical cancer. And we've done this in the context, of course, of the 2020 launch of the Elimination Initiative, where WHO has specified targets across the cancer control continuum, the 3 pillars of cervical cancer control: scaling up HPV vaccination, HPV-based cervical screening, and treatment for invasive cervical cancer and also for pre-cancer. So one of the first demonstrations of modelling across the spectrum that we've been able to do is to look at the impact of elimination delays. Now, here's the original elimination impact prediction, which was done pre-crisis, where we looked at the potential for elimination starting scale up in the year 2020 to save lives across 78 low-income and lower middle-income countries. And looking at the bottom here, this is for the elimination scenario, the purple line. We had predicted around 300,000 lives saved by 2030, 14.6 million lives saved by 2070, and over 62 million lives over the course of the century from the combined impact of vaccination, screening, and treatment services scale up. So what does a delay in rolling out elimination actually mean in the context of these numbers? There have been delays on elimination efforts. From the vaccination perspective, we've seen disruptions to existing school-based vaccination programs in many countries with variable catch-up success, delays to initiation of new programs in LMIC, disruptions to ongoing trials of one-dose vaccination, and the potential for a complex impact, of course, of COVID-19 on vaccine hesitancy as it relates to HPV. In the screening and treatment space, unfortunately, disruptions to established screening programs have occurred worldwide, with pauses and even in the case where there haven't been explicit pauses to programs, reduced participation. Also, we've seen supply disruptions impacting the ability to scale up HPV testing with competing reagents and systems needed for COVID-19 testing, as well as significant and substantial disruptions to cancer treatment services. So we have looked at what the cost of this might be. And just to summarise some of the preliminary estimates, here's the additional deaths that could occur over the 78 low and middle income countries over the long term for each single year elimination scale up is delayed. Unfortunately, that's a significant number, 326,000 deaths, roughly half due to vaccination delay, 40% due to screening delay, and a significant proportion, nearly 50,000, due to cancer treatment scale-up delays. So this is not to say that countries shouldn't prioritise COVID response. Of course, that is what is happening on the ground in countries. But our aim by doing this, of course, is to help to quantify the long-term impacts of decisions and to help ultimately in the next phase of our modelling in helping decision makers re-estimate the effects of reinvigorated elimination efforts. So I think in doing this, our aim is again to help countries in reaffirming their commitment to elimination. Now back to the CCGMC, where we're heading is that we are intending to combine all of these results and make them available to stakeholders, to countries, to policymakers in what we're calling a COVID and cancer observatory. Our intent is to make these systematic review results available, to keep them updated and to make them interactive for policymakers and to build on these findings over time. Allied with the evidence from systematic reviews, it will feed to data-driven modelling. We're constructing a global, multi-country responsive platform which will incorporate disruption and recovery data as it emerges, and will be continuously updating the best predictions for COVID impact on cancer, providing this as an interactive tool to policymakers so that they can look at the impacts on cancer outcomes in their country setting. So in conclusion, I think that it's important to reflect that modelling had already demonstrated its importance to pre-pandemic policymaking, but we've seen it, I suppose, start to come into its own in the pandemic era. And for modelling COVID impact on cancer, the data and infrastructure requirements are in fact extensive, as I've tried to outline. The silver linings, I suppose, in all of this are that for modellers, there is, of course, probably a much better understanding of the importance of timely access to data, as well as the benefits and the limitations of the modelling enterprise to informing decision making. And for clinicians, consumers, patients and policymakers, we hope that ultimately this will all result in better informed policy and recovery strategies, and even the potential for accelerated evaluation of innovative approaches and technologies. I just want to finish with a quote from Tim Hanna and colleagues. What has been clear in many countries' responses to COVID-19 is the inability to weigh the direct impact of the pandemic with the wider acute and long-term impact on conditions such as cancer. This necessitates data that is complex to collect, takes time, and requires careful analysis. But sadly, the pandemic has thrown into stark relief this clear evidence gap. And I'd like to thank all of my many collaborators, the 200 individuals who participated in the CCGMC, the partner institutions, UICC, the International Agency for Research on Cancer, the Canadian Partnership on Cancer, and the International Screening Network, as well as my institution, the Daffodil Centre. Thank you very much.
Thank you very much, Dr. Canfell. Next, we're going to hear from Natalie Fitzgerald, who's the Director of Performance at the Canadian Partnership Against Cancer. Natalie.
Thanks, Craig. Thanks for inviting me to be here with you today. I'm really happy to be sharing with you a little bit about the Canadian Partnership Against Cancer and talk about some of the exciting modelling work we've been doing related to COVID and cancer screening services in Canada. The Canadian Partnership Against Cancer is a federally funded organization with a mandate to accelerate action on cancer control for all people in Canada. We work with the 13 provinces and territories and other partners to reduce the number of people who get cancer, ensure more people survive cancer, enhance equitable access to high quality care, and improve the quality of life for those affected by cancer. As the partnership is the steward of the Canadian Strategy for Cancer Control, which contains 8 priorities that span the continuum of care and bring equity to the forefront, including 3 people-specific priorities identified by our First Nations, Inuit, and Métis, related to culturally appropriate self-determined care, as well as self-governed research and data systems. The strategy also identifies 4 key enablers of the system that span across all priorities, from research, data, innovation, and information. Our modeling work falls under the second enabler, maximizing the impact of data. Through enhanced collection of health system data, working with analysts to make sense of that data, and then translating that information into digestible, policy-relevant products, we can inform system planning efforts to help us prioritize resources as we continue to battle through and recover from the pandemic. When the pandemic began, we immediately felt the importance of understanding what was actually taking place in the system. Our current data infrastructure is fragmented and not always as up to date as we'd like. We began collating as much information as we could to understand how the pandemic had affected prevention efforts, access to cancer screening programs, if cancer detection rates were down, and how the delivery of cancer care had been affected. Using modeling, we've been able to look at both the short-term and long-term impacts of some of those service disruptions. We've also been looking ahead at what pandemic recovery looks like, providing guidance on what aspects of care need to be highly prioritized and what can perhaps safely wait. And while health human resources has always been a challenge in our country, in part due to a very vast geography, we're seeing the burnout and fatigue across many healthcare professions. Coming out of the pandemic, we also don't want to lose some of the great innovative practices that have emerged, such as drastic shifts in terms of the availability of virtual care. So we need to consider what new models of care can help to address some of these human resource constraints, and modeling can help us with that. And finally, the pandemic has really illuminated the health equity gaps very clearly in our country. Communities that have faced persistent systemic challenges in accessing healthcare in Canada have been disproportionately affected by COVID-19. Our recovery efforts must be equity focused and ensure that we're not leaving any groups behind. So without randomized control trial data and very little real world evidence on how to respond to a global pandemic in the 21st century, we're fortunate to be able to use projection modeling to inform policy and planning decisions. The partnership, in collaboration with Statistics Canada and many other expert advisors and partners, have developed a microsimulation platform called OncoSim. This publicly accessible tool is available online and has been developed and enhanced over the last decade to address relevant policy and planning questions. OncoSim can be used to generate new scenarios through modifiable input parameters, project future outputs for health outcomes, looking at physical and human resources in the system, as well as exploring the costs of different interventions. Through this tool, we're able to compare the impact of different policy and planning decisions in short and long term, and identify the most cost-effective or optimal strategies. Our team at the partnership also provides user support, both for those wishing to use the model directly online, as well as analytical support for those who need support running the analyses. So having invested in this tool meant that when the pandemic hit, we were able to make fairly minor modifications to ensure that the model could address pandemic recovery response. We're very grateful to have been invited to participate in and co-sponsor the COVID and Cancer Global Modeling Consortium, which Karen has just described. This consortium has been an invaluable resource to modelers around the world who have had a forum to share data, discuss methodologies, and input on potential policy scenarios that could inform the way forward. Comparative modeling efforts have been critical to validating our models and optimizing their performance. And within Canada, we've really benefited from this work, with the consortium being able to apply it at both the national and provincial and territorial levels. We've been able to adapt some of these scenarios to support some of our partners who are seeking modeling results to better understand what they might expect in their own jurisdictions and what different interventions and strategies would look like in terms of health outcomes, impact on human resources, and finances. We've also been very fortunate to collaborate with other modelers in Canada, like Talia Malagan, who you'll hear from next, to consolidate some of our modeling efforts and share our findings. So I'll just share with you a few examples of the work that we've had underway, and Karen spoke to this project in her presentation. One of our first pandemic-related modeling activities through the consortium was to compare the colorectal cancer screening models. These kinds of comparative analyses are so important to validate that our models, in this case from the Netherlands, Australia, and Canada, produce similar and plausible results. Unsurprisingly, all models predicted that delays in accessing colorectal cancer screening would result in excess deaths, underlining the importance of maintaining screening activities through subsequent waves of the pandemic. And through sharing our model inputs, methods, and results, we've been able to enhance and expedite global efforts to understand the impact of COVID on cancer, as well as within Canada to inform our recovery. Another modeling analysis focused on interruptions to breast and colorectal cancer screening, which was showcased in Statistics Canada's report on the social and economic impacts of the first year in the pandemic. This analysis was done in collaboration with many Canadian modeling and cancer screening experts across the country, exploring how severe the impact could be based on how long screening services were interrupted. The results found that a 6-month disruption for breast cancer screening could lead to 670 more advanced stage cases of breast cancer and 250 additional deaths. And for colorectal cancer, a 6-month disruption could lead to 2,200 more colorectal cancer cases and 960 more deaths. And of course, longer disruptions would lead to even greater loss. These are important findings to begin to quantify the magnitude of the impact as health system planners face impossible decisions about resource allocation, health human resourcing, quality of care, and patient safety. And lastly, I'd like to highlight an analysis that explored different approaches to catch up on colorectal cancer screening. We've estimated that nearly 500,000 Canadians missed their colorectal cancer screen in the first few months of the pandemic, which if not screened soon, could lead to an excess 400 colorectal cancer deaths. And with scarce colonoscopy resources, the surge to catch up cannot be dealt with overnight. The model was able to explore a few different scenarios, from waiting until those individuals were recalled at their next 2-year reminder for screening, increasing the threshold of what would be considered a positive test to reduce follow-up testing required, to slowly working through the backlog over different time periods. Our modeling showed that through a small increase in colonoscopy resources of 4%, a catch-up program could be implemented over the next 24 months, which would avert the majority of excess deaths projected. I will say, prior to the pandemic, I never thought modeling projections would be a household topic around the family dinner table, but it has certainly been normalized throughout many households and as well much more commonplace in healthcare policy and planning discussions. Modeling evidence now more than ever is a critical piece of the decision-making puzzle, especially where real-world evidence and randomized controlled trial data doesn't yet exist. However, finding access to high-quality and real-time data for model inputs continues to be a challenge and can introduce uncertainty in the projections. OncoSim has been a long-time investment of the partnership, and it has certainly paid off to be able to quickly adapt such a sophisticated and complex model to address new challenges in the cancer system. However, not all jurisdictions have the analytic capacity to develop models and understand the analyses. This speaks to the value and the need for multi-jurisdictional collaborations and to support the adaptation of models for broader policy and planning purposes. And finally, we need to better incorporate all voices in these kinds of analyses. This includes data that represents underserved groups, diverse voices around the table to inform the analyses from planning to dissemination, as well as increased capacity among underserved groups to support self-governed and self-led analysis. Through this, we can support health system planners to make the best possible policy decisions through the pandemic and beyond, reflecting the needs of all of our populations and promoting the delivery of high quality and equitable cancer care. Thank you.
Thank you, Ms. Fitzgerald. Now I'd like to introduce Dr. Talia Malagan, who's an academic associate at the Gerald Bronfman Department of Oncology at McGill University in Canada. Dr. Malagan.
Thank you, Dr. Earl, and thank you to CPAC for inviting me to this deep dive session. I'm very excited to be presenting our modeling work that we've done with the McGill Task Force on the impact of COVID-19 and cancer control and care today. So before we start, I have no conflicts of interest to declare, and the work I'll be presenting today was funded by the Canadian Institutes of Health Research. So I'm sure I have no need to tell you that the COVID-19 pandemic has severely disrupted cancer services worldwide. And it is widely known that cancer outcomes are very sensitive to care delays and to delays in diagnosis. But unfortunately, the pandemic-related impacts will take a very long time to measure due to the time lag between diagnosis, treatment, and final outcome and the final outcome of cancer survival. And so in these situations where the impacts can take a long time to manifest, decision models are useful tools to project outcomes and uncertainty into the future and analyze the impact of different decisions that we make today. And so the objective of this research was to use a decision model to predict the long-term impacts of the pandemic on cancer outcomes in Canada in terms of cancer incidence, mortality, and life years lost. So to do this, we used a microsimulation model, which is a dynamic individual-based stochastic model, which was programmed in C++. And this model simulates 25 different cancer sites using pre-pandemic incidence rates and net survival by age, sex, site, and stage from the Canadian Cancer Statistics 2018 and 2019 publications. And in the model, new cancer cases are diagnosed and they're followed up until either their death or the end of 2030. So at the bottom here, I have a schematic which summarizes a little bit how this could look like. So we could have, for example, in the model, a woman who is diagnosed with breast cancer at age 56. And normally, if there had not been a pandemic, she would have been diagnosed in 2020 and her treatment would have started in 2020. And maybe for this particular woman, she would have died from other causes before dying from breast cancer. But unfortunately, due to the pandemic, in the world with a pandemic, the model would resample for this woman a new diagnosis date and a new treatment date based on data. And in this particular case, due to the delay in her diagnosis, this woman would potentially die from breast cancer much earlier than she would have done otherwise and lose 3 years of life. So this is basically how the model works. It's based on delays that we see. It tries to resample essentially what would be the expected death dates for cancer cases due to the pandemic. And the way that we model delays in the model is that we use monthly and yearly changes into 2020 to 21 procedures compared with 2019 procedures. So for example, on the right-hand side here, we have the percent change in cancer surgeries that was observed in Canada in 2020, 2021 versus the same month in 2019. So we see that, you know, in April and May, there were nearly 20 to 25% reductions in the numbers of cancer surgeries which were performed in Canada. And so the model takes this data and uses it to model differences in the volume of cancer procedures over time. And this is how delays are integrated into the model. And so there is an assumption that misdiagnoses and treatments, which are over the monthly capacity of the model, get placed on the backlog, which increases during months where capacity is lower than expected. And the base case assumption is that each 4-week delay in diagnosis and treatment for all cancer sites and all treatment modalities leads to a 1.06 times increased hazard of cancer mortality based on data from a systematic review by Hannah and colleagues. Oh, and this is an error. It should say 2020, not 2016. They published their results in 2020. And actually, these are the results. So basically, the fundamental question is how long can cancer diagnosis and treatment be delayed before it has a negative impact on cancer survival? And how can we quantify the effect of delays on cancer mortality? So this is the fundamental question that the model is trying to answer and to project into the future. And so the systematic review had estimated that each 4-week delay in cancer surgery leads to an increase in the mortality rate of about 6 to 8% for many common cancer sites. And this is the base case assumption that we've integrated into the model. So we'll show you some results from the model. It's obviously not everything, but these are the main results that we found. So on the left-hand side, what we have is the predicted cancer incidence per month in Canada, in both a no pandemic scenario, which is the gray line, and assuming that in the pandemic scenario, which is the red line. And in the pandemic scenario, we assumed that each 4-week delay in cancer diagnosis and treatment would lead to a 6% increase in the rate of cancer mortality. And we assumed that starting June 2021 of this year, that we would be able to restore pre-pandemic treatment volumes. So there would not be necessarily an increase in treatment volumes, but that we were able to recover sort of pre-pandemic volumes of all cancer procedures. And so we see on the left-hand side that due to delays in diagnosis, there are expected to be fewer diagnoses made in 2020. But the expectation is that these cancer cases have not disappeared and that we will eventually be diagnosing them sometime in 2021 and 2022. And on the right-hand side, you see the impact that this has on cancer deaths. And so we see that starting from 2020, the combined delays in diagnosis and treatment are expected to lead to increases in the number of cancer deaths per month. And so, although this increase might appear very small, this is because this has been scaled per month. If we were to look at the results per year, which is this slide here. So this is the number of excess cancer deaths that were predicted by the model per year starting from 2020. And so we see that, we can expect some thousands of excess cancer deaths over the next 10 years in Canada due to diagnostic and treatment delays. And the year where we expect there to be the highest number of excess cancer deaths is likely to be 2022, so next year. And in 2022, the model predicted in the base case scenario that there could be up to a 6% increase in the number of excess cancer deaths over the expected number that there would have been had there been no pandemic. And importantly, we modeled different scenarios where we assumed different surge capacities and changes in treatment capacity over 2021 and into the future. And so in our base case, we assumed that in 2021, we would be returning to sort of the pre-pandemic baseline. And so the medium red scenario you see there is our base case where we just return to baseline. However, you see that if we were able to increase treatment capacity, so the light red bars here, then we would be able to substantially mitigate the number of excess cancer deaths that are expected into the future. Unfortunately, the opposite is also true. If we continue to be under pre-pandemic level treatment capacities during the course of 2021, then we could expect even more excess cancer deaths over the next decade than are predicted in the base case scenario. So to summarize, if cancer treatment capacity is recovered but not increased in 2021, then the model predicts that we could expect around 21,000 excess cancer deaths and 355,000 life years lost over the next 10 years in Canada due to pandemic-related cancer care delays. Importantly, when we looked at different scenarios, increasing treatment capacity by at least 10% over pre-pandemic levels in 2021 could substantially decrease this excess cancer mortality. And this is because by increasing treatment capacity over pre-pandemic levels, it would allow to clear any accumulated treatment backlogs that have occurred during the course of the pandemic. But also importantly, it helps to prepare for a future increased demands for cancer treatments due to the many cancers whose diagnosis was delayed during the pandemic and who are expected to be diagnosed this year and who will be requiring treatment. And so we do expect that there will be higher than normal demands for treatment over the next few years. And so it will be necessary to increase treatment capacity to deal with that increased demand of cancer treatments. So the results, this is only a fraction of the results today. We have published these as a preprint, so you can always look at them. The link is provided here. And we are developing a web application with in-kind support from the Canadian Partnership Against Cancer to further explore the results by Canadian province. So if you have further questions, you can always email me at the end. Thank you.
Thank you, Dr. Malagan. So now I'd like to ask some questions. I'm going to direct this first question to Dr. Canfell, but please, any of the speakers feel free to jump in. And my question is, how should policymakers use these results? How would they know that they're trustworthy? We know that some of it is based on real data, but some is based on assumptions. How should a policymaker use the results of modeling?
Thanks, Dr. Earl. That's a great question. Look, I think there's been a lot of discussion about the value of modeling and models, of course, in the context of the pandemic. And I think, as all of the speakers alluded to in our presentations, that's probably raised awareness, if you like, about modeling and what it is capable of, and also its limitations. I would always encourage the end user of a model to ask penetrating questions of modelers. In particular, what's really important is to understand the level to which the model is data-driven, and to understand the level of care in the development of a model, and in particular the level of, the technical term is validation, but the level to which the model predictions have actually been checked against real-world data in a prospective way. Prospective predictions have been checked against real-world data, and the model has been shown to hold up before we turn our hand to predicting the future, that we can show that the model has validity, that within the range of assumptions that are being made, the results are robust, they're repeatable, and that we can quantify uncertainty in a sensible way. So, in the end, I would really encourage the end user of a model, which is often the policy decision maker, to subject we, the modelers, to close, tough questions, to really try and understand, if not the details, at least the key characteristics of a model and what data it is using and what its uncertainties and limitations are, and to really ask for that demonstration of validity. I think just, the point I'd like to make, actually, and again, it's come out, I think, in all of our presentations, is that, there are many, many models in the world, and a model can be constructed with software these days in a matter of minutes, in fact. But, I think it's, what I think all of the presentations have really emphasized is the value of prior investment in careful, designed, data-driven models that have that extensive validation that I've alluded to. In our team, we've been working for over 20 years in just one cancer, cervical cancer. We've been working on a decade on colorectal cancer models. And so some of the results that I showed you are actually results that they're our first results for a reason, because we had well-developed and well-validated models to draw on. And these were around pre-pandemic investments. So one of the things that I would, I guess, call from out of here is that out of this experience is that research investments really need to think of models as long-term infrastructure investments. It's just as important, I would argue, as investment in something like a biobank. It's an incredible resource. It takes time, it takes care, it takes teams of researchers, a lot of effort to develop, but once it is developed, it can then be turned very quickly to new and emergent and urgent problems, such as we've seen, of course, in the pandemic.
Thank you. Maybe following up a bit on that, Ms. Fitzgerald, you and Dr. Malagan have presented models focused on Canada. How do we know how generalizable those models could be to other countries?
Well, I think what's important is to look at, as Karen mentioned, what data was used to inform those models and how context specific they are. So each jurisdiction may have different population-based needs, different risk profiles, different resource constraints that they're contending with in terms of understanding a policy or planning decision. So I think some of the value of the modeling consortiums is to see how these models work together, whether they're in alignment, they're moving in similar directions. And certainly that can help inform in other jurisdictions. But it is quite important to look at each jurisdiction's own specific context. And certainly models can be adapted to do that, to ensure that those results are generalizable in different contexts. And maybe just to build off the last question, which Karen, I loved your response. Just to note that planning decisions or policy decisions are never made in a vacuum or based on one piece of evidence. So really it comes down to what the modeling says, what local evidence and data says, what community groups are needing, and what the resource constraints are in each of those jurisdictions to inform any planning decision.
Thank you.
If I can add
yes,
to that,
please,
maybe.
Malagan.
Yeah, thanks. So I think particularly in the context of COVID-19 and cancer, at least in my experience, the model results are very sensitive to changes in the number of treatments and in the number of diagnoses that are particular to a specific jurisdiction. And so I think this does highlight the importance of gathering that data, of measuring exactly how many fewer screening tests are we doing, how many fewer treatments are we doing. This is vital data that does change from one jurisdiction to another, and that will have major impacts on cancer into the future. And so I'm sure different countries have been affected very differently by the pandemic. And so in order to be able to project, for models to be able to project into the future these things, we need to gather that data and make it available. It's very important data.
Well, thank you very much for that. We're at the end of our time. So I want to thank all of our speakers for excellent presentations and discussion, and to thank everyone for watching. Goodbye.